Welcome back, guys. Today we're gonna talk about the new system, which is the respiratory system. We're gonna divide this system to 5 videos. First video gonna include embryology. Second video gonna include the physiology. Third and fourth video gonna include the pathology, and the last video gonna about the pharmacology. Let's start about the embryology first. The embryology of the lung or the respiratory system at all, it's divided into 5 stages. The first stage is embryonic stage, which is from week 4 to week 7, and the second stage is pseudoglandular. The third stage is canalicular. Fourth stage is circular, and the last one is gonna be alveolar, and it continue after birth. So, to make it easy to memorize, the first one is embryonic stage. It starts from lung bud and ends in the tertiary bronchi. And pseudoglandular is ending in the terminal bronchiole, and canalicular is ending with alveolar duct, and the circular ending with the terminal sac as it is named, and alveolar, which is ending with alveoli or adult alveoli, and it is starting at the week 36 and end at after 8 years of birth. So, embryonic, it is containing lung bud, trachea, bronchial buds, main stem bronchi, secondary and tertiary bronchi. So, when we talking about the embryonic starting from lung bud and esophageal bud is in the same origin. So if any errors happen in this stage, it's gonna cause something called tracheoesophageal fistula, and we already talked about it in the gastrointestinal system, which is abnormal opening between the two endothelium of esophagus and trachea, and cause the food and the liquids go through this fistula from the esophagus to the trachea, causing choking and cyanosis for the child. The pseudoglandular stage, which is starting in week 5 and ending in 17, this stage, the respiration is impossible because it's ending in the terminal bronchiole, and there is no gas exchange till the terminal bronchiole. The gas exchange happens after the terminal bronchiole. So that means the breathing is gonna be in the canalicular, and it is happening in end of canalicular stage. Yeah, that means the breathing can be started, but it's not sure. It can be starting in the week 25th, and as we said, it's ending with alveolar duct. Some gas exchange can happen in this time. Respiration capable at week 25th. Pneumocyte development starting at week 20. We're gonna talk about the pneumocyte in this video in the end. Circular, which meaning in the sac, terminal sac. Also the breathing is okay here. Alveolar, which is converting the sacs to separate alveoli, which is 100% capable to breathe. And at birth, it's gonna be 20 to 70 million alveoli, and when this is done at age 8 years old, it's gonna be around 300 to 400 million alveoli. In utero, breathing occurs via aspiration and expulsion of amniotic fluid, because there is no air inside the uterus, increasing the vascular resistance throughout the gestation. At birth, the fluid gets replaced with the air, so decrease the pulmonary vascular resistance, which then give the baroreceptors, and the pressure and resistance can cause a lot of change in the child after birth. So that's closing the BDA, closing a lot of foramen oval between the two atrium, because the oxygen was coming from the umbilical cord, not from the lung. So in this picture here, they make it easy to memorize. Also, we talk about the embryonic stage, which is starting from week 4 to week 7, and we said it's ending in the tertiary bronchi, so the ending in the terminal bronchiole, canalicular ending in the respiratory bud, and circular ending in the sac, alveolar sac, and the alveoli ending with the ending with alveoli ending with a separate alveoli can capable to breathe. This circular ending we said that the breathing started in the week 25th. It's be able to breathe in week 25th, so that if the infant gets born after week 25th, there is possibility to life. So let's talk about some abnormality or malformation happen for this embryological development. Pulmonary aplasia and bronchogenic cyst. Pulmonary hypoplasia is most common thing associated with the Potter sequence, which is, we already talked about it in the renal system, which is oligohydramnios containing pulmonary hypoplasia or oligohydramnios T twisted lung and chain, or renal agenesis, poorly developed bronchial tree, abnormal history associated with congenital diaphragmatic hernia, and the Potter sequence, which is called bilateral renal agenesis, and the bronchogenic cyst, which is caused by abnormal budding of foregut and dilation of the terminal or large bronchi, and this dilation causes trapping on some fluid on it. So round, sharply defined, fluid filled on CTX, and air filled if it gets infected. Generally asymptomatic but can drain poorly, causing airway compression and recurrent chest infection. So let's talk about the club cell and some histology in the respiratory here. Club cell main function for a club cell is detoxification of the toxins, like degrade toxin and secrete the surfactant. This is the main function for a club cell. It is columnar or cuboidal. That's why it's secreting surfactant. So alveolar cell type, we have 3 types of cell. Type 1 pneumocyte, type 2 pneumocyte, and alveolar macrophage. Type 1 pneumocyte is the most common compartment of the cells in the lung, and 97% of the alveolar surface, thin line, and the main function is gas exchange. But type 2 pneumocyte, it is a cuboidal, and the type 1 we said is squamous. Type 2 is cuboidal, and it's minor, it's not too much, like it's according less than 3%, but it's most important than type 1 because it is acting as a precursor for type 1 and itself also precursor for type 1 and type 2, and it secretes the surfactant, which is the most important thing, and we have a large problem with surfactant right nowadays because the maternal mother. So what is the surfactant? Surfactant is the liquid secreted from type 2 pneumocyte causing decrease alveolar surface tension, decrease in a collapse, decrease in a recoil, and increase in compliance, which is the good things. Composed of multiple listin, mainly DPPC, and listin synthesis begin over week 20 of gestation and achieve mature level at week 35. Corticosteroids important for fetal surfactant synthesis and lung development. So we're gonna talk about the corticosteroid now in RDS, but there is a law here called law of Laplace. Law of Laplace means that collapsing pressure is 2 times of surface tension divided on the radius. So alveolar have decreased tendency to collapse expiration as the radius increase. So if the radius increase, so it's down, the surface tension gonna increase, the collapsing pressure gonna increase. So alveolar macrophage, is macrophage found in the alveoli. Phagocytosis, the foreign material which is found in the alveoli. The main keyword for the alveoli, for alveolar macrophage is hemosiderin laden macrophage. If they said they found hemosiderin laden under the microscope, so you should know this is a hemosiderin, this is a macrophage of the alveoli, and sometimes they call it HF cell, may be found in the setting of pulmonary edema and alveolar hemorrhage. The NRDS, what is the NRDS? Is a neonatal neonatal RDS, neonatal respiratory distress syndrome, which is caused by surfactant deficiency. So, surfactant, you said, it's decreasing the collapse of the alveoli and increasing the compliance. So, if there is deficiency, there is increased surface tension and causing alveolar collapse. And it appears as a ground glass in the X-ray. You see here, it's a ground glass appearance on X-ray. And the risk factor for NRDS is the prematurity. The infant born before 36 years old or 36 weeks. Maternal diabetes can cause increased fetal insulin, or C-section is one of the risk factors because C-section is decreasing the stress in the less stressful in the infant, and we know that steroid is one of the stress hormones. So if they didn't get the stress, they cannot get steroid hormones, so it's gonna be affecting the surfactant. So the treatment is maternal steroid before birth as a prevention, or exogenous surfactant after birth if we found an RDS there. How we can know this before the get birth? How we can know if this infant have an RDS he will have an RDS after birth? So we know it by LS ratio. What is LS? LS is listing sphingomyelin ratio. It should be more than 2. If it's less than 1.5, so this is the predictor for an RDS. So the treatment, we said, as a prevention, we give a steroid for the maternal. Most of the time they're given something called dexamethasone, and or exogenous, they give it direct to the lung by a tube. So therapeutic supplemental O2 is dangerous because it can cause retinopathy, prematurity, or intravascular hemorrhage, or bronchopulmonary dysplasia, and that's it. So let's go for the anatomy. Anatomy for the lung, we know the respiratory tree. The respiratory tree divided in 2 zones. The first zone is just for conducting the air, taking the air from the outside to the place it should be exchanged. And the respiratory zone where is the O2 and CO2 get exchanged. So, conducting zone is the lung airway, consists of nose, pharynx, larynx, trachea, and bronchi. Airway resistance high. Here the resistance is high because this part of the lung can't be dilated, or the compliance is bad, poor compliance, because it's composed of cartilage and bone and this stuff. But this is the first part of the conducting zone. So smaller airways consist of bronchioles that further divided to terminal bronchiole and the least resistance. So after the bronchiole, these airways have the ability to dilate and constrict, so the resistance is gonna be low here. So to know the conducting zone is the trachea, from outside, nose or mouth, pharynx, larynx, trachea, bronchi, and bronchioles till the terminal bronchioles. And cartilage and goblet cell extended to end of the bronchi, as we said before. That's why we said it is a highly resistant. We said the stratified ciliated columnar cells primarily make up epithelium of a bronchus and extended to beginning of the terminal bronchioles. Then transition to cuboidal cells, clear mucus, and derive from lungs. Airway smooth muscular cells extended to end of the terminal bronchiole, spares beyond these points. Okay. So let's go for the respiratory zone, which the area there is a gas exchange happening here. Lung parenchyma consists of respiratory bronchioles, starting from respiratory bronchiole, alveolar ducts, and alveoli. The last 3 parts. Again, conducting is from nose or mouth, larynx, pharynx, trachea, bronchi, and bronchioles till the terminal bronchioles. Primary, secondary, tertiary, and terminal bronchioles. and all of this is just conducting the air, and it's considered as a dead space. We're going to talk about it in the physiology. And the respiratory zone is the respiratory bronchiole, alveolar duct, and the alveoli. So the gas exchange not only happen in the alveoli, it usually is also happen in the duct, alveolar duct, and respiratory bronchiole. So in this photo here, we can know, before the photo, let's talk about the histology. Most cuboidal cell respiratory bronchiole, then simple squamous cell up to alveoli. Cilia terminate in respiratory bronchiole, alveolar macrophage, clear the brise, we said alveolar macrophage, hemosiderin. We talk about it in the last page. Hemosiderin laden and participate in the immune response. So in this photo here, we can see the conducting area till the terminal bronchiole. We said till here it's high resistance, here is low resistance, because we said it's composed of cartilage and it can't be dilated. And here is composed, if there is no cartilage, so it can be dilated. Respiratory bronchiole, respiratory duct, alveolar duct, and the alveoli. Alveoli is composed of, we said, is composed of simple squamous and type 1 cell, type 1 pneumocyte. And the respiratory bronchiole, we said, smooth muscle, squamous epithelium, and simple cuboidal for secretion. And the cilia is not found in the respiratory zone, just found in the conducting zone. Okay, so let's go for the anatomy, simple anatomy for the lung. We know that the right, and we have two lungs, right and left lungs, and let's make it bigger like this. Okay, two lungs, right and left lung. The difference between right and left lung is that the right lung have 3 lobes and the left lung have just 2 lobes, because the heart occupying the place of the middle lobe. And there is something special for the left lung called lingula, which is coming under the heart. So homologous of the middle lobe, we said, instead of the middle lobe in the left lung has space occupied by the heart. We said that. Relation of the pulmonary artery to bronchus at each lung hilum described as rails. Right, anterior, left, superior. So what's the relation between the lung, the pulmonary artery to the bronchus of each side? We have the bronchial going to each side. Right side is anterior to the right side and posterior to the left side. Superior to the left side, sorry. Anterior and superior. Carina. What's carina? Carina is the division of the trachea given to right and left bronchus. Posterior to ascending aorta and anterior medial to the descending. So the aorta is posterior and anterior. Anterior medial. So the ascending coming from front and go back posterior. Coming from the back to the anterior. And right lung is more common site of the inhaled foreign body, because its right main stem bronchus is wider, move vertical. The bronchus go like this, and division to 2 parts. So this is the right and this is the left. So when the air come in, the foreign body is easier to continue this side, easier more than to go the right side, because it's wider and it is more vertical and shorter more than the left side. So while supine, in supine position, usually enter the superior segment of the right lower lobe. Superior segment of the right lower lobe. While lying right side, if you lie in the right side, they usually enter the right upper lobe. Right upper lobe. And while upright position, enter the right lower lobe. So it's most common in right lower lobe, but if you supine position right right lower loop, but it's upper part, and it's just only in the upper loop if it in the right side, if you lie on the right side. And what we have in the last thing in the anatomy for the respiratory system is the diaphragm structure, and it's easy to memorize. There is a three structure passing through the diaphragm. We have an esophagus, inferior vena cava, and the descending aorta. And you should know the level when this crosses the diaphragm. So the inferior vena cava crossing the diaphragm at T8, vein cava, A. 8 letter, 1, 2, 3, 4, 5, 6, 7, 8. So 8 letter, T8. Vena cava crossing the diaphragm at 8. And esophagus, 10 letter, ESOFGAHAGUS, it's 10 letter, crossing at T10. And aorta is descending aorta, is 12 letter. So it's crossing at the T12. So diaphragm is innervated by C3, 4, and 5, which is the phrenic nerve. Pain from diaphragm can felt in the irritation is in the shoulder, as the 5, and trapezius ridge is the 3 and 4. So here other bifurcation common, carotid bifurcation at C4, trachea bifurcation at T4, abdominal aorta bifurcation at L4. A lot of 4s. So for today, this is the anatomy and embryology for the respiratory system, and we're gonna talk about the system of the physiology of the respiratory system next video. Thank you for listening.